Today we are covering prioritization using the ABC framework, which stands for airway, breathing, and circulation. On the NCLEX, this is not just a guideline. It is the absolute rule for nearly all prioritization questions involving acute physiological distress. Your primary job is to identify the most unstable patient, and instability is always defined first by a threat to their airway, then their breathing, then their circulation. Let's consider an exam-style question. You are assigned 4 patients. The first patient is a 70-year-old 2 days post-hip replacement who is complaining of 8 out of 10 pain. The second is a 25-year-old with a newly diagnosed anxiety disorder who is crying and hyperventilating. The third is a 55-year-old who just returned from a bronchoscopy and is making a high-pitched audible crowing sound on inspiration. The fourth is a diabetic patient with a blood sugar of 180. The correct answer is to see the bronchoscopy patient immediately. That high-pitched sound is stridor, a sign of a severely compromised closing airway. This is a life-threatening emergency. The NCLEX loves to test this. Pain is a distractor. While important, it does not trump a compromised airway. The anxious patient's hyperventilation is a breathing issue, but it is linked to a psychosocial cause and is not an obstruction. The diabetic patient is not in immediate danger. The airway is always first. Now let's look at breathing. Imagine you have a patient with chronic COPD whose oxygen saturation is normally 90%, and today it is 89%. In the next room is a patient who had abdominal surgery 6 hours ago, who was stable, but whose respiratory rate is now 28 breaths per minute, and they are using their accessory muscles to breathe. The surgical patient is the priority. This is a classic NCLEX trap, testing acute versus chronic conditions. The COPD patient is at their baseline, which is not an emergency. The surgical patient is showing an acute, sudden change in their breathing status, signaling potential complications like a pulmonary embolism or atelectasis. This is an unstable patient whose breathing pattern has changed dramatically. Finally, let's talk about circulation. You have a patient with a superficial leg laceration that has moderate bleeding, but their vital signs are stable. In the next bed is an elderly patient who just received their first dose of a new antihypertensive medication and now has a blood pressure of 88/50 and a weak, thready pulse. You must see the elderly patient first. The moderate bleeding is a circulation issue, but it is not causing systemic instability. The patient with the low blood pressure is in a state of potential circulatory collapse or shock. This is an unstable C problem that takes priority. The most common exam trap is getting distracted by something that seems urgent but isn't life-threatening from an ABC perspective. Severe pain, high anxiety, and controlled bleeding are all designed to pull your attention away from the subtle signs of true instability. To help you remember this on the exam, use this phrase: scan for ABCs, forget the rest, to pass the test. This mental shortcut forces you to consciously ignore distractors and look only for the most critical physiological threat. Before you look at pain scales, lab values, or psychosocial needs, you must first ensure your patient has a patent airway, is breathing effectively, and has adequate circulation. Master this, and you will correctly answer a huge number of prioritization questions.